So we are going to do the King tube, the LMA, and the eye gel. Remember, combi tube is also something that we talked about, but because we don't physically have any, we're not going to do the check off on those today. So I'm going to start with the King tube. Remember, this is sized based off of height. All right, so the size 3, which is what I have, has a yellow top, and this is for patients who are between 4 and 5 feet tall. The size 4, which would have the red top, is for patients that are between 5 and 6 feet tall, and the size 5, which has the purple top, is for patients who are over 6 feet tall. Okay, we do have the 2 smaller ones, the size 2 and 2.5 for pediatric, that are based on height and weight as well. So this has the size on it, and it tells me how much air it will take to inflate these cuffs. So this says between 45 and 60 mLs. So this is a 60 ml syringe. I'm going to inflate this cuff to test it. So my partner right now would be pre-oxygenating my patient for about 2 minutes. Now this has a hole in it, a leak, as you can see. So if this was a real patient, I would not continue to use this, but for these purposes, we're still going to use it, okay? Now, I can preload this syringe and have it ready to inflate while it's on here, but as soon as I've inflated it, once it's in, I need to pop it off or the air is gonna come right back out, okay? So my partner would have been pre-oxygenating with the BVM. I'm gonna get ready, I would lubricate this, and now I'm going to come in, and ideally you can use the tongue jaw lift, because that's gonna really keep the C-spine the same. You could also, for the other two, I'll show you, kind of just manipulate the head, but this will be the best way for this. This blue orientation line on this side, I want to start that at the side of the mouth like this. And then as I'm lifting up, I'm going to rotate and push this in and down. Now, if I get a lot of resistance, I want to stop. And now I'm going to continue to hold on to this tube, and I'm going to inflate the cuffs. Now, again, I need to make sure that I take this right off so that air doesn't come right back out into the syringe, okay? Now I need to confirm the tube placement. I'm also looking to see where this is at. Like this is at 12 centimeters at the teeth there. That's gonna help me judge for any potential displacement in the future. All right, if that moves. So now I'm still holding on to this. I'm gonna come in and I'm going to ventilate. I would be looking for chest rise, and this has a leak, so you're not gonna see a lot on this guy. But we would be looking for chest rise and fall. We're listening to lung sounds, and we're also gonna use capnography. All right, so I could either use the color change, which remember is not gonna give me a lot of continuous feedback, or I could use this device here. This would hook up to my cardiac monitor, and this is gonna give me that continuous feedback for numbers and also for the graph of the waveform, okay? And so then once I've got this on here, I would want my partner to hold the bag, or I could just take it off for a second. I'm still holding on here, and I can use my tube holder. All right, and so this one's pink, so it's pediatric, but it's the same concept of the tube holder. This has a bite block built into it right here, so that if the patient were to start biting, they can't actually bite through the tube. Of course, if they were to start waking up, we would want to consider removing the tube, but that's there for their safety as well. So the tube will go right into there. I'm gonna tighten this down just a little bit, but you don't want to tighten it down so much that it kinks off the tube. And then this piece would come underneath and secure. And again, this is a pediatric one, so that's why it's fallen a little bit short, but you would secure it right there. And now you would be able to let go of the tube once it's secure, okay? Now, if I was getting ready to take this out, then I would take this off. I would want to deflate the cuff, and I'm gonna pull it straight out with the curve of the face. Now, if I was listening to lung sounds here and I was only hearing them on one side, then that means I'm not necessarily all in the right spot. It could mean that there's an injury to the lung, but if I've ruled that out and I just know that maybe my tube is just a little bit too deep, all right, that happens a lot of times, especially with intubation, but it can happen with the blind insertion as well. What I would want to do is pull the air out, and I'm gonna pull back just a few millimeters. I'm not pulling the tube completely out. I'm pulling it back just a hair, re-inflating, and then I would test it again and see if I would get chest rise on both sides, all right? And again, if I didn't, or there was something wrong with the tube, or the patient's waking up, I'm getting ready to take it out, I would completely deflate and then pull straight out with the curve of the mouth like this, okay? All right, so looking at the LMA, this one's gonna be a little bit too small for him, but I wanted to make sure it would go in there. And so remember, this one is gonna be weight-based, so it's written right here on the tube. This is between 20 and 30 kilograms, and this is more predominantly used in the hospitals, and it tells me on this piece how much air it takes to inflate it. So this is saying about 17 mLs is what it would take to fill this up. I'll put 20 in there to test it. Put that in, you'll see that's inflating a little bit, and that's just enough. So I'm looking to make sure it doesn't have any leaks or anything like that. Again, my partner would be pre-oxygenating. Now I'm ready to put it in. I can leave this hooked up. I would want to lubricate it. And now with this guy, again, I could kind of put his head into a sniffing position, and just as its name implies, it's almost like you're taking a big sniff, so you're just kind of tilting the head back a little bit, which would allow you to input this. But if you run into some issues with the tongue, or if they have a C-spine injury, you could fall back to that Bass maneuver or tongue jaw lift to get this in there. Okay, so you're not gonna have to turn this or do anything crazy. It does have that orientation line, so you can start at the corner of the mouth, but most people would just insert this with the curve of the face right here. And again, this is a little small for him, but I'll come in and inflate. Now I want to confirm my tube placement. So again, once I'm ventilating, I'm looking for chest rise, I'm listening to lung sounds, and I would put my end tidal on as well. With this particular one, you can use that same regular sized tube holder because it will fit in that spot. I'm gonna show you the iGel one in just a second, which is just a little bit different. All right. So if I was gonna take this out, deflate the cuff, pull straight out with the curve of the face. Now for the iGel, this one does not have to be inflated or anything. It forms its seal. It is kind of like a jelly material. This is also based on weight. So this is the size 3, and it says here it is between 30 and 60 kilograms is what it's meant for. And so same thing, I would want to lubricate this. My partner would be pre-oxygenating. I just want to make sure there's no obvious deformities or pieces broken on it when I take it out of the package. And then I'm going to come in and insert this. And he doesn't have any lubrication on this one, so it might not go all the way down like I want it to, but we'll see. All right, so I put it in, and now I would want to confirm tube placement for him. Same thing. I am watching for chest rise and fall, listening to lung sounds, and I can add end tidal. Now for the LMA, again, it's a little bit wider, so the traditional tube holder won't fit just because you see how wide that is in comparison to the other tubes. This is a tube holder like this that is meant for this. It's a little bit wider, and so you put this in. It has that same bite block on it, but it will. It's meant and molded to that size of the tube. All right, so we could put that on, strap this down on this side, just like we did with the other one, and now you're good to go. Now, some of them like have these small spikes or whatever you want to call them on it. That's also for a different type of tube holder that might come in the package with the iGel, and that can be used as well. So that is this guy right here, and this already has the lubrication attached in the package too, but I'm just going to set that to the side. And so with this one, see all these small holes? That's gonna be what you attach to this. So this is kind of like a one-time use thing, which they all should be, only one-time use in the field. But I would set this up. I'm holding it down, pull this one up, also hold it down. And it's a little less stable than the other one, but it is a viable option if that's all that you have, okay? No deflation or anything for this guy. If you need to pull it out, then you would just go out straight with the curve of the face. All right, so those are the 3 tubes themselves. Now I'm going to show you a couple of other things that I mentioned yesterday with the soft suction, and then I'm going to get to talking about gastric tubes in just a second. So this is our soft suction catheter, which we looked at yesterday, which is going to attach here. We'll remove the yonker, put the soft suction catheter right on here. Now we said a couple different things that we could do. We can use this for infants' mouths, we could use it in the nose, but we can also use it for the tubes, okay? So like for the iGel right here, if I was suctioning straight down this tube, that's gonna be suctioning anything that is coming out of the trachea, right? Because even though this distal end is probably in the esophagus blocking it off, this is kind of making a cup around the trachea. So if I go straight down the tube, if I have anything coming out of here like secretions, that's coming out of the lungs, okay? Now on the eye gel, they have this side port right here, right? Very small hole, if you can see that right there. And this is meant to suction anything coming from the gastric area. And it's actually gonna come out at the end down here. And this one might be a little bit too wide. It might not make it all the way to the end, but we'll see. I don't think it's going to, but it's coming from here. So that very small hole at the tip would be coming anything from the gastric area. So if you had vomit, if you had blood that was coming up the esophagus, we would be able to suction that from this small area on that side of the tube, okay? Now the eye gel is kind of unique that it also has this another additional adapter on here for additional oxygen. So even though you're giving your oxygen right through your BVM, you could have it hooked up there, but you could also hook it straight up to this port to provide additional if for some reason your patient was really under oxygenated or what have you, okay? So that's for that one. For the king tube, most of them, it's gonna be the the opposite, it's on the back and not on the side. If I was suctioning down the tube, there's nowhere for it to come out, but it would be coming in because this is our holes right here that are blowing the air into the trachea. So down the tube would be suctioning up anything coming out of the lungs. On the back side right here, it has this small port. And it's the same thing, it's gonna come out the end because remember this end is in the esophagus. So if it's suctioning vomit, blood, or anything coming out of the stomach, of the esophagus, that's where it's suctioning from, okay? And so most LMAs do not have those ports. That's something kind of unique to these two, but I have seen some that do, just depends on the brand and manufacturer and all that good stuff, all right? Now, one last thing for us to consider is going to be the use of a gastric tube, and that's either going to be orogastric, which is abbreviated as OG, or nasogastric, which is abbreviated as NG, all right? And so this is a national registry thing that we need to talk about, but is not a North Carolina thing for EMTs. Okay, and so if you've never seen the gastric tube before, this is what it looks like. This is what they would use if they needed to do continuous suction of the gastric contents, like if they were pumping your stomach, or let's say my patient had airway issues, so I'm aggressively managing his airway, but he's got some gastric bleeding, and that's coming up, and it needs to be continuously suctioned. This is where this would come into play. All right, so if I was doing this the OG route, then I would want to, I could put it in beside, all right? If I had one that was small enough, I could potentially put it in the back side of this tube, but usually like if the patient is intubated or what have you, it will just kind of go down beside the tube and it would go just down into the mouth. Now it depends on how you need to measure it as to what you're gonna do with it. Like if I was gonna put this into his mouth, I need to put this end wherever I kind of want it to stop. So usually down here about the carina is a good spot. And so I would measure down to this point, and then I'm measuring up behind his ear and then to his mouth. All right, and that's really where I kind of want it to go for the mouth side of things. If it was gonna be to his nose, I would do that as well, behind the nose, behind the ear and back up to the nose, okay? So again, if I was putting the tube in, I would pass this right beside it. If I was putting this into the nose and he was awake, then I would do this while he was swallowing. So I would give him a cup of water, and every time he swallowed, I would just pass it a little bit, and then he would swallow again, and I would pass it a little bit, and so on and so forth until I get it as deep as I want it to go, and then I could secure that with tube tape to the side of his face. Okay, now once this is in place, that's where this end comes in as far as suctioning. So if I'm not suctioning, I'm gonna keep them capped off together like this. If I need to suction out of it, what I'm gonna do is pop this off, attach this to my suction, and now it's either gonna suction for a short period of time, or you can leave it as continuous. And that's what a lot of times they do in the hospital if they've got someone who needs, again, that constant pumping of the stomach or removal of blood or what have you. Okay? All right, thank you.